Hi guys, good afternoon. My name is Tahani. I'm currently a student at Qualitest Learning Institute. I'm also a volunteer at West Demerara Regional Hospital as a phlebotomy technician. My lecturer is Miss Yvette Irving, and my main objective in this video is to outline the main aspects of phlebotomy. So what is phlebotomy and how is it connected to the medical field? First of all, phlebotomy, phleb means veins and otomy means incision. Phlebotomy is the act of drawing or removing blood from the circulatory system through a cut or puncture in order to obtain a sample for analysis and diagnosis. Phlebotomy is also done as part of the patient's treatment for certain blood disorders. So there are two ways phlebotomy can be performed, which is the venipuncture and also the dermal puncture, which is also known as the capillary puncture, which I will be going in more depth later on this video. Functions of a phlebotomist. Well, first of all, without phlebotomists, the doctors cannot do their job. The doctor rely on us, the phlebotomists, in order to get their patient's diagnosis. So the responsibility or function of phlebotomists is to prepare patient for collection procedures associated with laboratory samples, collect routine skin puncture and venous specimen for testing as required. We prepare specimens for transport to ensure stability of sample. Our job is also to maintain patient confidentiality, promote good relations with patients and hospital personnel, perform appropriate laboratory computer operations, collect and perform point-of-care testing. We also perform front office duties, current procedural terminology, coding, and paperwork. The equipment and supplies used by a phlebotomist. First, we have the phlebotomy chair. I have some stuff that we use as the phlebotomist in the hospital, which is the blood collection tubes, our gloves, the non-sterile gloves, an assortment of needles, and well, this is the needle and this is a syringe. So it's an assortment of needles and syringes. Our tourniquet is where we tie off from the patient's hand to restrict blood flow. We always remember that the tourniquet can't be on within 1 minute or else it can cause hemoconcentration. We have alcohol swabs, gauze, sharps container and transportation bag, a blood specimen label, and equipment that is always used by a phlebotomist or always on hand is a pen. Site for venipuncture or venipuncture sites that are acceptable, which is basically the vein. But as phlebotomists, we have three choices of vein that we need to use, which is the first choice of vein is the median cubital vein, the second vein is the cephalic vein, and the third vein is the basilic vein. However, these veins came in two patterns, which is the H pattern and the M pattern, which we see mostly on patients. So the median cubital vein, which is located near the center of the antecubital area, it is the preferred vein for venipuncture in the shaped pattern. It is typically larger, closer to the surface, better anchored, and more stationary than the others. It is the easiest and least painful to puncture and the least likely to bruise. Second choice of veins that we use is the cephalic vein, which is located in the lateral aspect of the antecubital area. It is the second choice vein for venipuncture in the H-shaped pattern. It is often harder to palpate than the median, and it is fairly well anchored and often the only vein that can be palpated in obese patients. And lastly but not the least, which is the basilic vein. The basilic vein is a large vein located on the medial aspect of the antecubital area. It is the last choice vein for venipuncture in either venous distribution pattern. It is generally easy to palpate but is not as well anchored and rolls more easily. Possibility of accidental puncture of the anterior or posterior branch of the medial cutaneous nerve, brachial artery, and it punctures in this area also tend to be painful. So as a phlebotomist, where we see the the basilic vein, we don't usually attempt it where, as always, we're not always subjected to one hand. We usually go on to the other hand to see if we'll see the other two veins. If we're not seeing or gaining access to these veins, then we use the basilic vein. However, it's not recommendedly used for first choice because it can, if we could possibly hit the brachial artery and it could cause damage to the person, which could also cause paralysis to the patient. And as phlebotomists, we don't want that to happen. Also, here is a diagram of the H pattern vein and the M pattern vein. And also, I was given the opportunity at the hospital where I took some H pattern veins on a patient and M pattern veins on a patient. So here it is. So as you can see, the tourniquet is tied off 3 to 4 inches, and around here is the antecubital fossa is exposed. So here is the veins where we phlebotomist has to bore the patient. As I said, here we have 3 types of veins. Here is the median cubital vein, the cephalic vein, and the basilic vein. As I said, the first choice is median, the second choice is cephalic, and the last choice but not least is the basilic vein. So this is another choice of venipuncture that we can go on and bore if we're not getting access to the arm. This method is called the dorsal, where we could bore the patient on their hands or as well. As you can see, there's a vein right here. We could bore right here, and also a method of collection that would be much easier is the butterfly ring infusion set. We have the types of needle and their gauges. Special needle attached to collection, which is the 15 to 17 gauge, the hypodermic needle, which is the 18 gauge, the multi-sample hypodermic 20 gauge, the multi-sample hypodermic 21 gauge, and the multi-sample hypodermic 22 gauge. Lastly, we have the butterfly 23 gauge. I'll be going in a little more depth on these types of needle and their gauges. The special needle attached to collection bag, the typical use of this is collection of donor units, autologous blood donation, and therapeutic phlebotomy. Therapeutic phlebotomy is performed when a patient has polycythemia, which is an increase of erythrocytes or known as red blood cells. We have the hypodermic needle, the 18 gauge. The typical use for this is it's used primarily as a transfer needle rather than for blood collection. Its safety issues have diminished use. We have the multi-sample hypodermic needle, the 21 gauge. Typical use for this, it is considered a standard venipuncture needle for routine venipuncture on patients with normal veins or for syringe by blood culture collection. We also have the 22 gauge multi-sample hypodermic needle. Let me show you what it looks like. So as you could see, this is the 22 gauge hypodermic, multi-sample hypodermic needle. Lastly, the type of needle is the butterfly needle, the 23 gauge. The typical use for this is used on the veins of infants and children, on difficult or hand veins of adults. Here is what the butterfly needle looks like. We usually use this on geriatrics or on little kids that have finer veins or difficult veins. But this is the most preferred method of collection for children and geriatric patients. Components of the evacuated tube comprises of the bevel, the shaft, the threaded hub, the rubber sleeve, the tube holder, which is this, the evacuated tube, the needle with stopper, phalange, and assorted system. Here's a diagram of what the components of the evacuated tube really looks like. And also I have one here. This is a method of collection used on patients in collecting blood, where we insert this in the vein and just push the evacuated tube in order to get blood. Secondly, we have the components of the syringe system, which comprises of the bevel, the shaft, the hub, and the needle. And it also comprises of the graduated barrel and the plunger. So, as a phlebotomist, my favorite method of collection is this method of collection, the syringe system, because when we bore the patient in the vein, the hub indicates to us that blood is flashing, and that indicates that we're in the vein. However, I have a assembled syringe system here. Here is the plunger. Here is the graduated barrel. And at the tip of the needle is the bevel. I'm sure you won't see it, but it's at the tip here. And this is the hub. When we bore the patient in the vein, this hub indicates to us that there is blood flow. Types of vacutainer tubes that we use as phlebotomists are in the laboratory, which is the gray tubes, the orange tubes, the royal blue tubes, the tan tubes, the yellow tubes, the light blue tubes, the red glass tube. However, there are two types of red tubes. We have the glass tubes and we have the plastic tube, and the green tubes and the lavender tubes and the pink tubes. I will be going in more depth on each of these vacutainer tubes. So first we have the gray tubes. The stopper color for it is gray. The additives that's inside of the gray tube is the sodium fluoride, the potassium oxalate, and ethylene diamide tetraacetic acid, which is known as EDTA. The function of these additives, it removes calcium and prevents clotting, binding and precipitating calcium in the form of an insoluble salt. The gray tube that's available in the Department of Chemistry. So secondly, we have the orange tubes. The stopper color for this is orange. The additives that's inside of this orange tube is thrombin. Function of additives is it converts the fibrinogen into the fibrin, which is necessary for clot formation. The orange tube that is found in the Department of Chemistry. The third type of vacutainer tube is the royal blue tubes, or it's also known as the trace element tubes. These royal blue tubes are used for drug screening or testing for toxicology. The stopper color for this is royal blue. The additives for this could be none. It could have ethylene diamine tetraacetic acid, or known as EDTA, or sodium heparin. The function of these additives is prevent clotting by inhibiting thrombin, which is an enzyme needed to convert fibrinogen into the fibrin necessary for clot formation. The department for this is chemistry. The fourth type of vacutainer tube, we have the tan tubes. The stopper color for this is tan. The additives in this tube is the ethylene diamine tetraacetic acid, known as EDTA. The function of additive is removing calcium from the blood by binding or chelating it to form an insoluble salt. This makes calcium unavailable for the coagulation process, so the blood in the tube is prevented from clotting. So the department for this is also chemistry. The fifth type of vacutainer tube is the yellow tubes. The stopper color for this is yellow. The additives that is found is the SPS and ACD. The SPS stands for sodium polyantiol sulfonate and the ACD stands for acid citrate dextrose. The function of these additives, it prevents coagulation by binding calcium. It is used for blood culture collection because in addition to being an anticoagulant, it reduces the action of a protein called complement, which destroys bacteria. The tubes that are found in this department is the microbiology or blood bank, which is also known as immunohematology. The sixth type of tube in type of vacutainer tube is the light blue tubes, where the stopper color for this is light blue. The additive for this is sodium citrate. Function of this additive, it prevents coagulation by binding or chelating calcium. This tube can be found in the department of coagulation. The seventh type of vacutainer tubes is the red glass tubes. The stopper color for this is red. The additives is none. Function of additives, its silica particles activate clotting. Department is found in chemistry, blood bank, and serology or immunology. So in the hospital where I work, we usually take off this red tubes, which has no additives. We usually take off this for biochemistry. And yes, there is another red tube, which is known as plastic tube in red. The stopper color for this is red. The additives is clot activator. The function of additives is that it enhances coagulation in tubes used to collect serum specimens. The tubes that can be found in this department is chemistry, which is also known as biochemistry as well. The eighth type of vacutainer tube is the green tube. The stopper color for this is green. The additives found in this tube are lithium heparin and gel separator. Function of the additives, it prevents clotting by inhibiting thrombin, which, as I said earlier, thrombin is an enzyme to convert into fibrinogen. The tubes that are found in the department are chemistry. The ninth tube type of vacutainer tubes that are found are lavender tubes. The stopper color for this is the purple or lavender. These tubes are basically used in the hospital almost every day for collecting CBC. The additives in this tube contains only ethylene diamine tetraacetic acid, which is known as EDTA. The function of additive is that it removes calcium from the blood by binding or chelating it to form an insoluble salt. This makes calcium ions unavailable for the coagulation process, so the blood in the tube is prevented from clotting. The department for this is hematology. The ninth type of vacutainer tube is the pink tubes, which the stopper color for this is pink. The additive is also contain ethylene diamine tetraacetic acid. The function of this additive, it removes calcium from the blood by binding it or chelating it to form an insoluble salt. This makes calcium ion unavailable for the coagulation process, so the blood in the tube is prevented from clotting. The department that is found using this tube is immunohematology or blood bank. So as I said, most of these tubes don't come in chronological order. These are just some of type of the tubes that are found in certain departments. So next we have the order of draw and the rationale for venipuncture. As a phlebotomist, we have to follow the order of draw because without following it, we can misdiagnose the patient or make the patient get inaccurate result. That is why we always follow order of draw. So the first order of draw is blood cultures, or known as sterile collections. The tube stopper color for this is yellow sodium polyantyl sulfonate, or SPS, sterile media bottles. The rationale for collection of order for this, it minimizes the chance of microbial contamination. The second order of draw, which is an order, is the coagulation tubes. The tube stopper color for this is light blue. The rationale for collection of order is the first additive tube in the order because all other additive tubes affect coagulation tests. The third order of draw that we have is the glass non-additive tubes. This is how it looks like. So the tube stopper color for this is red. The rationale for collection of order for this, it prevents contaminations by additives in other tubes. The fourth order of draw, we have the plastic clot activated tubes, or the serum separated tubes, known as SSTs. The stopper color for this is red. The SSTs can be red and gray rubber gold plastic. The rationale for this, it is filled after coagulation tests because silica particles activate clotting tests, which is the carryover of silica into subsequent tubes can be overridden by anticoagulant in them. The next order of draw, which we have heparin tubes, the tube stopper color for this is green. The rationale for this is that heparin affects coagulation tests and interferes in collection of serum specimens. Followed by the ethylene diamine tetraacetic acid tubes, which is also known as EDTA tubes. The tube stopper color for this can be lavender, pink, or purple. The rationale for this, it is responsible for more carryover problems than any other additives. It elevates sodium and potassium levels. It chelates and decreases calcium and iron levels. It elevates also prothrombin time and PTT results. So the last order of draw that we have in line is the oxalate fluoride tubes. The tube stopper color for this is gray. The rationale for this is that sodium fluoride and potassium oxalate affect sodium and potassium levels respectively, filled after hematology tubes because oxalate damages cell membranes and causes red blood cells known as erythrocytes morphology, and oxalate interferes in enzyme reactions. As I said earlier, phlebotomy can be performed into two ways, which is the venipuncture or the capillary puncture. So as well, there is an order of draw for capillary puncture collection order and the rationale. So the first order of draw for capillary puncture is blood gas specimen. The tube stopper color for this is green. The rationale for collection of order is it is drawn first to avoid introduction of room air as well as to minimizes microbial infection. The second order of draw for capillary puncture is blood smear. The tube stopper color is actually none. This is where slides are used. The rationale for collection of order for this is that a specimen for blood count is collected before tubes containing other anticoagulants and additives. This is to ensure that the blood will not begin to clot before this specimen is collected. Clots will affect the accuracy of the blood count. The third order of draw for capillary puncture is the EDTA specimen, which is known as the ethylene diamine tetraacetic acid. The tube stopper color for this is lavender or purple. The rationale for this is that a specimen for blood count is collected before tubes containing other anticoagulants and additives. This is to ensure that the blood will not begin to clot before the specimen collects. Clot will affect the accuracy of the blood count. So basically it's the same as the blood smear. The next order of draw for capillary puncture, we have the other additive. The tube stopper color for this is gray. Sodium fluoride and potassium oxalate affects sodium and potassium levels respectively. The next order of draw for capillary puncture is the serum specimen. The tube stopper color for this is red. The rationale for this is it is filled after coagulation test because silica particles activate clotting and affect coagulation tests. So the last order of draw for capillary puncture is the newborn screening specimens. The tube stopper color for this is the newborn screening form. The rationale for this is that blood for newborn screening specimens should be collected separately from a different site. So, for example, babies, we cannot prick the baby's finger. Pediatricians can do this, and also we're trained to do this. We can prick their heel, which is also, we can do this for a test called dry blood spot procedure, which later down in the video I will be going in more into the heel stick procedures in capillary puncture. So next we have the components of a phlebotomy tray. The phlebotomy tray comprises of the alcohol swabs, the gauze squares or cotton balls, the assorted evacuated tubes, syringes, syringe transfer device, various size single and evacuated system needles, butterfly collection sets are known as butterfly infusion sets. We have the micro collection equipments, the tourniquet, the disposable gloves, the marking pen, and the sharps container. Steps of routine ETS procedure are known as evacuated tube system. First of all, evacuated tube system is an example of method of collection used in venipuncture. For example, when a patient brings a requisition form to the phlebotomist, there will be a lot of tests done ordered by the doctor. This is when we use the ETS method. This is the most easiest method when there's a lot of tests to be done. So the steps of routine ETS procedure is that we review and accession test requests, we approach, identify, and prepare patient, we verify diet restrictions and latex sensitivity, we sanitize our hands, we position patient, apply tourniquet, and ask patient to make a fist. We select our vein, release tourniquet, ask patient to open fist, clean and air dry site where we use alcohol swabs, and wipe in concentric circles. We prepare equipment and put on our gloves. We reapply the tourniquet on cap and inspect needle for any defects. We establish blood flow, release tourniquet, ask patient to open fist, fill, remove, and mix tubes in order of draw. If we mix tubes vigorously, it can cause hemolysis, which is also the breakdown of red blood cells or erythrocytes. Then after that, we place the gauze, remove needle, activate safety feature, and apply pressure. Then we discard collection unit, we label tubes, observe special handling instructions, check patients, and apply bandage. Dispose of used and contaminated materials, and then we thank patient, remove gloves, and sanitize our hand. And lastly, we transport the specimen to the lab for further testing. So this is what the ETS looks like.
Demonstrating A. Routine ETS venipuncture.
So next we have the steps of venipuncture of a hand vein, butterfly, and ATS holder. Yes, we can take off blood from a hand vein where we have difficult veins on the arm. So this other method is called the dorsal, where we bore patients, difficult patients, using the butterfly infusion set or the butterfly, and we use the ETS holder. So here I'm going to connect the ETS holder with the butterfly, making sure it's secure. So this is where we use this on geriatrics and kids, and the steps of venipuncture or a hand vein, butterfly, and ETS holder. Well, it's basically the same ETS procedure that I went through, which is the only thing that we changed the method of collection, which is this. So the next method of collection is the syringe method, and it's the same as the evacuated tube system procedure. The only difference between this is that we changed the method of collection to syringe, which is this. So steps for a pediatric venipuncture. So first of all, pediatric has to do with kids. So any child wouldn't like to get bored or anything. So as a phlebotomist, it is our job to explain the procedure to them very nicely and calm. And after that, we will tell them it will hurt, but not for long. We are not allowed to tell them that it won't hurt at all. And if we just perform the venipuncture just like that, and they start crying and so on, it can elevate their white blood cell count. And as a phlebotomist, we don't want that to happen. So steps of pediatric venipuncture is the same as I mentioned earlier on the ETS procedure, but pediatric, we have to be patient and we have to be calm with them. So I will go over back the venipuncture steps for pediatric. So we review and accession test requests. We approach, identify, and prepare patient. We verify diet restrictions and latex sensitivity. We sanitize our hands. We position patient, apply tourniquet, and ask patient to make a fist. We select vein, release tourniquet, ask patient to open fist. We clean and air dry site. As I said, we clean and air dry the site using alcohol swabs, and we do it in concentric circles. We prepare the equipment and put on gloves. We reapply tourniquet, uncap, and inspect needle. We ask patients to remake a fist, anchor vein, and insert needle. Anchoring the vein means we put our thumb 1 to 2 inches in and insert in the needle in 15 to 30 degrees. We establish blood flow. We release tourniquet and ask patient to open fist. We fill, remove, and mix tube in order of draw. Always remember, we cannot mix tubes in vigorously because it can cause hemolysis, which is also known as the breakdown of red blood cells. We place gauze, remove needle, activate safety feature, and apply pressure. We discard the collection unit. We label the tubes. We observe special handling instructions. We check patient's arm and apply bandage. We also dispose of used and contaminated materials. We thank patient, remove gloves, and sanitize hands. And then after that, we transport the specimen to the lab for further laboratory testing. Next, we have the steps of a heel stick procedure. Heel stick procedure is done on babies or infants who could be a few hours old and so on. But however, a heel stick can only done on babies. So the steps of a heel stick procedure. For example, we can do a heel stick procedure for their blood grouping, or we can do one called for dry blood spot procedure. So first, we review and accession test requests. We approach, identify, and prepare patient. We verify diet restrictions and latex sensitivity. We sanitize hand and put on gloves. We position the patient. we select the puncture or incision site. So as in a baby heel, we always use the median plantar heel. Then after that, we clean and air dry the site in concentric circles using the alcohol swabs. We prepare the equipment, we puncture the site and discard the lancet or incision defects. We wipe away the first drop of blood because always remember the first drop of blood is tissue fluid. We label the specimen and observe special handling instruction. We check the site and apply bandage. We dispose of used and contaminated materials. We thank patient. We remove gloves and sanitize hands. And we transport the specimen to the lab. So steps for a capillary puncture, which is also known as a fingerstick procedure. Capillary puncture can be used for clotting time, FBS or RBS, which is known as sugar testing. So we review and accession test requests. We approach, identify, and prepare patient. We verify diet restrictions and latex sensitivity. We sanitize hands and put on gloves. We position the patient. We select the puncture incision site. Always remember, for capillary puncture, we use the middle finger or the ring finger. And we always use the lateral side of the finger. I will be posting a diagram of that. So after that, when we puncture the patient finger, the lateral side, we usually wipe off the first set of blood because the first set of blood is known as tissue fluid, and then we go on for the testing. After that, we place gauze and apply pressure, and if it's bleeding back again, we check the site and apply bandage. So basically, there is the same steps of ETS, but the only difference is that it's a finger stick procedure we are doing. The possible patient complications and conditions during a venipuncture, we have syncope and fainting. Well, syncope is the same as fainting. Syncope is the medical terminology for fainting. Patient may become dizzy and faint at a thought or sight of blood. It is caused because of rapid fall in the blood pressure, and it is an autonomic nervous system reaction. Next, we have the petechiae. I'm not sure to pronounce that, but it may occur following venipuncture. This may be due to a coagulation problem or abnormalities. And after that, we have another type that could happen, another complication that could happen is called hematoma formation. Hematoma formation following venipuncture can be painful and can potentially cause nerve damage. Among complications associated with phlebotomy, nerve injury is relatively rare but is potentially serious and often results in malpractice lawsuits. So if we bore the patient wrong or and cause them to get a hematoma, they can file a lawsuit on us. And it's not happened mostly in Guyana, but if we were phlebotomists working in the US, that could happen. So we try our best not to give them a hematoma. A hematoma is a mass of blood that can cause a bruise in their arm, and we try our best as phlebotomists not to do that during a venipuncture. Possible problem sites. When selecting a site for a venipuncture, we must always avoid these sites. We have the fistula or shunt. This is because risk or damage and infection in the surgically prepared access point for dialysis. So overall, we cannot just do a venipuncture on a patient who is going through a dialysis on that arm. Instead, we go on the other arm. The other site we avoid is the feet or ankles. This could happen because of risk of clot forming, especially in bedridden patients. However, there is a procedure where a doctor can take off a blood sample through their feet if we're not ever getting any access in at the arm or the hand. This is known as the femoral procedure, but only a doctor can do this. And after this, we have the mastectomy. Mastectomy is the risk of infection and lymphedema if arm on side of mastectomy is used. So mastectomy is basically the removal of breast when a patient has to remove breast surgically. So as a phlebotomist, we do not bore the patient hand when they did a mastectomy. The other site we try to avoid is edematous tattoos or edematous sites or tattoos, which is risk of contaminating specimen with tissue fluid lead from tattoo ink. That is why we always avoid the patients that have tattoo. We always use the other hand. The next site that we avoid also is the IV infusion site, which is known as the intravenous fluid. This is because the risk of diluting specimen with intravenous solution, which may cause inaccurate results. So we do not bore a patient when they have an IV in their hand, because it can cause inaccurate results for them. So that is why we bore a patient where they have no invasive or IV anywhere on the other hand. So we always use the other hand. The last site we try to avoid as a phlebotomist, we try to avoid the risk adjacent to hand, which is here. This is because risk of puncturing nerves, tendons, or arteries. We can use the risk adjacent to hand when we're doing arterial blood gas specimens. Steps to follow if a patient starts to faint. So, as a phlebotomy technician, when I was working at BEST, we not every day we will see normal patients. Sometime in the morning, we can take off a normal blood sample from a patient, and all of a sudden they can go into a syncope state. So the steps to follow if a patient starts to faint: we release the tourniquet and remove and discard the needle as quick as possible. We apply pressure to the site while having the patient to lower the head and breathe deeply. We talk to the patient. We physically support this patient. We ask permission and explain what you are doing. It is necessary to loosen a tight collar or tie. We apply a cold compress or wet washcloth to the forehead and back of the neck. We have someone stay with the patient until recovery is complete. We call first aid personnel if the patient does not respond. And after that, which is the most important thing we have to do, is we always document the incident according to facility protocol. So as I said, a phlebotomist always has to prepare for patients like these, always have to be on their head of game, because sometimes, not as I said, not every day we will have normal patients. We will have patients that can be weak and that can cause them to faint. So as phlebotomists, we have to be prepared for them as well. So that is the end of my phlebotomy project, my final project. I would like to thank you, Ms. Irving, for enhancing my knowledge on phlebotomy. I would like to thank Mr. Joshua Amin. Those assignments helped me a lot in phlebotomy as well. So, and also, I will be sharing my phlebotomy journey where I did my attachment at West Demerara Regional Hospital. I think that hospital has helped me a lot. I've got good experiences. I would like to thank Mr. Calvin Roberts for helping me to become a better phlebotomy technician, who have seen potential in me and has helped me in my weak areas. So, West Demerara Regional Hospital for the best teaching hospital in Region 3. So thank you, Miss, for giving me this opportunity as a phlebotomy technician. And I hope that one day I can be a medical lab technologist like you. So thank you very much, Miss.